Just go, you can do like 3, 2, 1 out. I don't know. Hi, so this is Tiffany, Rio, and Sima, and today we're going to be talking about RH incompatibility. We're going to start off by talking about some of the pathophysiology, risk factors, then we'll go into clinical manifestations, and Rio will finish by talking about nursing management. So, RH incompatibility happens when an RH positive child has a D antigen on the surface of its red blood cells and the RH negative mother does not. When the RH negative mother is exposed to the antigen, either through various tests or usually through pregnancy, the RH negative mother develops antibodies against the D antigen on the baby's red blood cell. And these antibodies will in turn attack the child's red blood cells, but this typically doesn't happen in the first pregnancy, it happens in subsequent ones. The antibody that's formed is an IgG, and it can cross the placenta barrier, and so it can affect the baby in utero, and this can lead to hemolysis of the red blood cells, which is also known as erythroblastosis, and if not treated, it can lead to fetal demise in the worst case scenario. So some of the effects that it has on the baby in utero are anemia, hepatosplenomegaly, which means that the red blood cells, because they're being destroyed by the mother, the liver and the spleen are working harder to produce more and produce more red blood cells. There can also be a buildup of fluid, typically in the abdomen. And after the birth, some of the things that you can see in the child are anemia, jaundice, hepatosplenomegaly, edema, and low muscle tone and lethargy. Some of the risk factors are if you have an Rh negative mother and an Rh positive father, because this is dominant, the baby is likely to be Rh positive. Any injections or procedures that might expose the mother to the baby's blood. This can also include trauma, any hemorrhaging during pregnancy, any intrauterine blood transfusions. And even if the mother does not give birth, if she has a miscarriage or an abortion, she still needs treatment because she will develop the antibodies if she's going to have any children.
Hi there. So clinical manifestations of Rh incompatibility. So this is what you might see if you're receiving patients on the end side of things. So it wasn't prevented, and now there is an incompatibility. So after birth, an infant may experience jaundice, and you can see that on the scan, the whites of the eye. They may have hypertonia, low muscle tone, anemia, and they're going to be more lethargic. So this is the very mild symptoms that one may experience, and they kind of range from mild to severe. If they are severe, these complications, we call them, of Rh incompatibility will be as severe as fatality or loss of function. So some of the loss of function can include brain damage, and basically that's the high levels of bilirubin deposit in the CNS tissues, and that causes the effects. And the hydrocephalus is that fluid buildup, and this can be fatal. If the infant recovers, there still can be residual effects on mental function, as mental retardation, changes in movement, reflexes, hearing deficits, speech deficits, and seizures. So how do we test in the clinic people coming in with this Rh incompatibility? So if they already have this incompatibility, they're pregnant, you can do a blood test and the Combs blood test and detect the antibodies to that Rh factor in the mother's blood. You can test the infant's blood in utero, the umbilical cord blood, and for high levels of bilirubin, and that's that byproduct again of the red blood cells. And then you can see take a sample of the blood post delivery of the infant and put it under a microscope, and you can look at the blood cell destruction should it be there, and it basically it's mutilated, torn apart red blood cells. So what is the prognosis for RH incompatibility? A full recovery is expected for mild symptoms, but the more severe, the tougher the prognosis is. So we really focus on primary prevention, screening, and treatment to prevent these complications.
So nursing management of RH incompatibility. As aforementioned, with preventative care, we have ROGAM. So there are a bunch of different names for that as well, as you can see under the heading there. And ROGAM suppresses the immune response in the non-sensitized mom. So we have mom with RH negative blood, and she was exposed through various means. When we have RH incompatibility, that means there could have been fetal-maternal hemorrhage. There was a possible transfusion during the pregnancy for any reason, miscarriage, previous termination of pregnancy for any reason. There can be trauma, as we've discussed with chorionic villi sampling or an amnio. You want to make sure that ROGAM is administered before, and there's tests, and also the test to see mom's blood type. So the indication, again, routine antepartum, usually the 28th week. This is the ROGAM preventative measure. The dose is intramuscular, and side effects are pretty uncommon. It's a fairly benign medication in terms of that. There may be an allergy or possible lethargy are the most common, but allergy is pretty rare. So again, RH antibody titer for the RH negative woman at 28 weeks gestation. The amnio, since we have incompatibility, amnio is recommended to check for bilirubin levels in the fetus. As Sima mentioned, these can be one of the complications, and so I want to check and make sure that the fetus is doing okay. Ultrasound checks to look for ascites, swelling, any other subcutaneous edema. There's a condition called hydrops fetalis. Intrauterine blood transfusion may also be recommended, especially if there's fetal anemia present due to the hemolysis. So phototherapy is something we've discussed for high bilirubin levels in the baby, and it's important nursing care around this that we keep baby well hydrated due to this constant exposure to the phototherapy, and make sure that thermoregulation is taken into consideration. Education and support around blood transfusions. Severe cases in hydrops fetalis and hemolytic disease of the newborn due to the RH incompatibility, there may be some action around clearing the fluid that can build up around the lungs, so pleural fluid extraction, medications possibly if there is severe edema. IV fluids are usually recommended for the baby for hydration. Sometimes in worst cases, the baby may need to be on a ventilator for breathing support. And with hemolytic disease of the newborn, sometimes intravenous immunoglobulin is recommended. Again, as aforementioned, the risk for hyperbilirubinemia is high due to the hemolysis. So in terms of nursing diagnoses, we can see that hemolytic diseases are one of the results and something that we would be looking out for. So our goals for care, this is really the most critical aspect in the nursing management. So we want to make sure that the baby receiving any therapy to excrete the bilirubin goes through without complications, making sure that the baby doesn't experience any complications from the transfusion. And really critical here is the family process. So we talk a lot about skin to skin and bonding with mother and baby in the first phase of life. And this is and will be disrupted if the baby needs to receive emergency attention within that critical first 72 hours of the RH incompatibility diagnosis. So the family is going to need to receive some emotional support and education around that. There will be some periods of separation of mom and baby, father and baby, or caregiver and baby. And so we want to make sure that during that time, mom and dad feel like they have some agency in the baby's care and they know how to care for their baby going forward. So there will be definite education going on. And as we've learned, the family ideally will be able to demonstrate appropriate home care in a teach-back method before leaving the hospital, so that the baby can be taken care of post-therapeutic intervention at home. And here are our references.